Is that
Okay. Okay. Good afternoon, everyone. Welcome to PICU Educational Rounds. Just as per usual, we are recording this, and you can put questions in the chat box throughout the talk, and then we'll have time for the questions at the end, or you could turn on your microphone and ask that way. Um, I will be handing over to my colleague, Dr. Jeff Burzynski, and he did not want a long introduction. So the only thing I'll say is that I once went to an ultrasound course in Chicago, and he was my teacher. So I look forward to the talk today. Go ahead, Jeff.
okay? Thanks, Val. Val, does that look okay? The screen?
We can just see like in small box. If you put it on the play, then we could
Right.
see.
Okay, let me just do this again then.
Okay.
Mhm. Better?
Yeah, that's perfect.
Okay.
Okay.
Okay, so what we're going to talk about today is sort of just an overview of critical care ultrasound. And for those of you who know me, that's kind of been an interest of mine for the last probably 10 years or so since I came back here and kind of got into it when I came back here in 2011, 2012. So then kind of got into ultrasound teaching south of the border and about 10 years ago, and then kind of have developed that niche over the years. So today we're going to talk about just where the technology stands, and we're kind of at a crossroads, I think, with respect to critical care ultrasound in terms of how to proceed and where to go from here. And we'll talk about that more at the end. Um, and we'll a little bit about what the generalist and resident needs to know, and we'll talk about the modalities that are useful, and then a little bit about the training and admin aspects as we've sort of evolved. And we can talk a little bit about the NICU because that's one of the leaders in terms of trying to really formalize the administration part of it. And then where are we really going? If is there anywhere else to go in terms of this technology? So first case, and then I guess if there's some people that might remember this kid, this is probably I want to say this is pre-COVID, so it's a 3 month old. He came in from northern Manitoba, kind of a standard Manitoba patient, respiratory distress, very little medical care prior to presentation. He showed up in the poor history. There may be a sense of chronic respiratory symptoms. The caregiver at the time was not the primary caregiver, so it was very difficult to really determine. Really had, uh, I guess it's not called failure to thrive anymore. It's called growth faltering, so not really gaining weight. Um, so kind of a standard patient that we see only in Manitoba, it seems like. And when I present this case south of the border, this is real. I get looked at like we're in some sort of third world country because it doesn't really happen that kids just present with strange diseases anymore with like that don't have medical care. So this is kind of a unique to us. So these are the vitals. This was in the ER. So decent blood pressure, tachycardic, hypoxic, hypoxic despite being on nasal prone oxygen and a respiratory rate of 50. So tachypnic, hypoxic, hypercapnic, but really no infiltrates. So we kind of got called, and then we have this gas here, or sorry, this X-ray here, and obviously, kind of if you if the anyone looking can see, like there's really very little. First of all, the heart is ginormous and the lung fields look pretty black actually. So yeah, this is 2018, so this is 6 years ago. So this kid went to the ward actually. I think it was, this looked like it was, sorry, so this is actually it's exactly 6 years ago on the December 20th. So this was a busy time. So I think got sent to the ward, bronchiolitis, and then the new nurse on after shift change was worried about the baby, so got to reassess. So maybe there was a big liver felt. So then the ICU got involved and did a point of care echo. So for those of you that I don't know, Val, can you see my pointer?
Yes. Yeah.
Okay, perfect. Yeah, okay. So if you this look, it's kind of confusing because this is such an abnormal looking picture. So this is a parasternal long axis. So this is just one of the parasternal views that are actually quite easy to get, particularly in a baby. And what I'm pointing at here is the left ventricle. So usually in this view, all you see is the left ventricle. You're not using this view to evaluate the right ventricle. So the LV is sort of off in this direction. The RV is on top, and it's this absolutely ginormous thing with very, very thick trabeculated walls. This is a sort of a subcostal view. Again, you can see the RV on top, and then you've got this very squished LV. So very, very abnormal. Like you can see how thick the RV wall is here. Really interesting. And this obviously changes the dynamic. And that's kind of the point of this technology when used in the critical care unit. Um, the diagnosis, I'll just reiterate. So when we use this, we're using this as a not as a diagnostic tool per se. This is where we really have to work together with cardiology because we're not using this to diagnose congenital heart disease, but we're looking at this like, okay, this kid doesn't really fit the picture of bronchiolitis. Is there something else going on? We've got a big liver. So obviously we see this and you're looking, and I'll reiterate this as the talk goes on in terms of how to use this technology in a proper way without um, I guess the right word is overstepping the technology and overstepping where we are as intensivists or ER docs um, in terms of cardiology. So this obviously abnormal, and I didn't diagnose the tiny pulmonary arteries. Obviously, that's so cardiology. We clearly got involved as soon as we saw this. So this kid had very, very small pulmonary arteries, only a millimeter in some places. Had an ASD that's kind of preserved some LV output at this point. Biventricular function was preserved, but really very, very few surgical options. And this kid was actually, I think, palliated in the sense that there was no surgical options, and he died several weeks later. So, in terms of how this changes management, and did it change the course of this patient? Ultimately, the child died. So, that's not the point here. The point is that we're using this technology in the point of care. So, we're using this as a sort of a almost like the stethoscope was used initially, right? We're using this to make diagnoses or sorry, make physiologic assessments is the better term that can pinpoint which way we're going. And so with this case, clearly big liver, big heart, there was something going on. So we put the probe on. There's a few other examples, I think, as this talk goes on, that we can look at how specifically we have changed for the better in terms of saving a life. Um, there's lots of examples of bronchiolitis being treated as bronchiolitis when there's actually a profound ventricular failure. So that changes your RSI management. So that's kind of where I'm getting at in terms of using this technology properly. Okay, so just briefly, history of bedside ultrasound. There's really decades of use prior to the last 10, 15 years, mostly in the adult world. Now it's really permeated throughout pediatric emergency medicine. Most pediatric emergency medicine physicians use it to a certain extent. In the adult ICU, it was probably 15 years ago uh, when it crept in from the OR, where it was used for vascular access primarily. Uh, Point of care echo, including transesophageal echo, is widespread in the cardiac ICU and the cardiac anesthesia of the adults. So now in the PICU, it's really evolved probably 10 years now, where a lot of people are grasping the technology. Having said that, it's not really standardized very well, and that's something we'll get at the end. Um, so anesthesia and NICU surgery all have expanded programs and training. So you can find any kind of training programs you want in any of these fields that are taking advantage of this newfound uh, I guess newfound interest in trying to advancing bedside ultrasound as a tool. You guys all seen this. So the one on the left is actually our machine in the ICU now. The one on the right is a butterfly, which is a handheld device that a lot of the adult DR docs are using, and have their own devices, and and that plugs right into a phone. And transport has a similar device that plugs into an iPad. So it's becoming smaller and smaller. And I think the technology on the right is really where things are headed in terms of the portability of it all. And there are some med schools that are giving out these devices as for first year med students. I'm not totally keen on that, but that's a separate story. So in terms of things that are relevant, not irrelevant. So the no-brainers are procedures and vascular access. So there's really like just in my career as an ICU doc, that has really changed from landmark-based vascular access to completely reliant on ultrasound for line placement, chest tube placement are the two main ones. There's really no one that does landmark-based vascular access, and as we see the baby's getting smaller and the line's getting bigger, it's really a no-brainer. And in the U.S., it's generally a requirement for billing even. So you can't bill for a central line placement without an ultrasound picture. So thoracic ultrasound, echo hemodynamic assessment is a little bit more gray. And we'll talk about that. Abdominal ultrasound, again, is there a need? Neuro ultrasound, as we are hiring new people, we are interested in some neurocritical care people. We can talk more about that. That's sort of a burgeoning field. And then how to incorporate it into the daily routine of the ICU. So the three things that really are like you get your image, you interpret it, and then you integrate it into the clinical um, presentation of the patient. So that's kind of the key point, which is why it's in a different color. The generation part, image generation, just getting the image is usually quite easy to train. It's just a matter of how to work it in. Because people are looking for black and white answers, and they want to make um, use numbers, and they want to things to make sense. And I think that's kind of where this technology is sort of getting, especially in peds, is not is we're kind of getting ahead of ourselves, and I'll talk about that. So how ubiquitous. So this is not quite 10 years ago, almost now. This is an ICU survey, basically, of how many people are using it and how many people find it useful. So in terms of usefulness, um, like, or is it, where's my, so usefulness, the IVC, and we'll talk about that, using it as the IVC. The difference between usefulness is confidence is the mean difference. So people found it very useful, but they're really not very confident. Same with LV ejection fraction, pulmonary edema, and sorry, I'll just go back to that. So that's basically, this is just showing how what intensivists want to use it for versus how confident they are. So people really want, and I see the attendings that are on this call, we and the residents, et cetera, are really interested for the most part in guiding hemodynamic management and trying to figure out what to do with these patients. And again, it's not very easy, and the evidence for that isn't really that good. So vascular access, like I said, no brainer. Lots of regulatory bodies in the US require it. Um, so the in versus out of plane technique, what I'm referring to there is watching the needle tip versus um, just X marks the spot. So you find the central line or find the vein, make a mark or whatever, and then poke. So very, very few people do that anymore. It's generally all in plane. So the point of ultrasound is to see the needle the whole way, see the needle tip the whole way. So that's what I mean. So there's the top right, you're seeing a long, so that's the long axis view. And again, that view, I don't know if the ICU docs that are on use the long axis view as opposed to the cross-sectional or short axis view. Um, The long axis view is very difficult in small vessels. So what we're doing there is we're looking at the length of the vein, as you can see, and you're just seeing the needle tip go right into the vessel. So it's very, very helpful if you can get this view. It's difficult because the beam of the ultrasound and the size of the patient often don't line up. The the out of plane, um, the out of plane or the short axis view is much more common, in that we can follow the needle tip down from the from the skin downwards. And this is just a view of this is another technique of using agitated saline just to determine. Like we've had a few over the years. Like probably Stasa can remember a few of these of lines that are inadvertently placed in arteries. So I sometimes will use this if I'm not quite sure in a kid who's pretty shut down. So you see this is a subcostal view. The top part of the heart that you can see is the right ventricle. So you're agitating saline and injecting into the vein, or sorry, into the central line. You can with a ultrasound probe on the heart, so you can see, yes, I'm actually in the vein, obviously, because you're injecting into the right side of the heart. So it's kind of an interesting adjunct for line placement, particularly in kids that are pretty shut down and you can't really tell, is this blue blood or red blood, or is it pulse cell or not. So moving on to thoracic ultrasound, um, this is again something that's useful. The NICU uses it differently than we do, and I think this again is very much uh, a yes or no type of answer. And that's kind of the thing when I do teach ultrasound, it's important to really grasp that you're not diagnosing things. So you're not giving causes. So like I don't like the use of it to diagnose pneumonia, bronchiolitis, that kind of thing. I don't think it's super useful. I think for us in the ICU and even in the sort of resuscitation in the emergency room, you're using it to rule things in or out. So is there a pneumo present? Is the ET2 and ETT in the right spot, i.e., like if you have no lung sliding, for example, and I'll explain what that is on the left side, it's probably in the right main stem bronchus, and it's very important and very easy to evaluate the whiteout on chest X-ray. There's been a number of examples last week when I was on call where we've had kids that have had very extensive whiteouts on X-ray, and it's a very simple, very easy test to say, okay, is this actually consolidation versus collapse versus fluid? And that's probably the main thing that it's useful for. And if it is fluid, then identifying where it is and how to drain it. Other than that, I'm not a huge believer in the concepts of looking at extravascular lung water with B lines, and I think that it becomes very subjective and very not super useful. I'm maybe not in a minority, but I know there are people out there that are trying to use it to find different things, and I just don't think the clinical utility is there, and I think we have to be honest with ourselves when we use this uh, and try to really keep things as simple as possible. So this is a pretty standard case, very easy. 3-year-old girl, cough, fever. I saw a million of these kids today in the urgent care. Local health center, respiratory distress and lethargy. So that's very standard winter presentation of bronchiolitis or pneumonia. So this is prior to our transport team, transported to the city, grunting, lethargic, tachycardic, maybe a bit hypoxic and very tachypnic. Again, hypercarbic, slightly respiratory acidosis. And there's your X-ray. And we see this all the time. So this is the main thing, I think. Pneumonia, or sorry, whiteouts versus pneumos are the real big thing. So diagnostic too. So here's your ultrasound. Very easy to tell for all of you that are not ultrasound people. You can tell like so there's your diaphragm here, that's your liver, all of this. So that's pneumonia, all of this white, or sorry, black You can see all the things floating around here, flipping around. That's all. This down here, sorry, this is all black. This is pneumonia, like really bad collapsed lung, consolidated. All of this is black, all these things floating around. So super easy, takes 30 seconds, and you've made your diagnosis and you know what the treatment algorithm is at this point. So in this way, having us see this at 9 or 10 at night, or even 6 or 7 in the morning without having to deal with a formal ultrasound, it's very easy to do and very, very useful. And so this is a tool that we can use all the time in the ICU for that. Again, just repeating another different view of really nasty pneumonia. You can see all the septations there, that just a complicated pneumonia with effusion. Same thing here. Like all of this is consolidated lung. There's your diaphragm here. So super easy to do. And this is, you can see the chest tube. And this is in the ICU after drainage. So really a nasty looking lung underneath. That's what we saw in ultrasound. And this is a few, this looks like it's in May of 2018. So this is 4 months later. And this was a little girl who was completely fine at this point, running around. So after getting the lung drained. So in terms of this is lung sliding, right? So on the left, you can see right along the pleural line. This is very clearly, you can see people have described this many different ways, and walking along a line or shimmering. And then you can see here on this side, there's really nothing. So this rules out a pneumo. Uh, Lung sliding that's absent doesn't necessarily rule in a pneumo. So you're looking this is as a rule out. So once you've got this in a clinical scenario, this is more accurate than an X-ray. So this would be an indication, depending on the clinical scenario, whether or not you're needling the chest or uh, putting in a formal chest tube, or like waiting for a chest tube. So this is a super easy, and I didn't explain the technique because that's not really what the rounds are about. It's mostly just this is what we can do, and that this is super easy. Takes 2 seconds. I mean, the like the little girl that's in bed 7, like when I put the unfortunately put hers, took me forever to put a central line in her. I did this afterwards because I was fairly certain that I had hit her lung, and sure enough, so she got a chest tube. And so that was we were able to do all that at once. So unfortunately, I'm spent 45 minutes trying to get a line in her neck and missed multiple times. So at least at that point, you can say, so we're not waiting an hour later and all of a sudden she has a deterioration and a tension pneumo. So it's very, very helpful at the bedside to get an answer very quickly. This is just another example of a large effusion and like the lung kind of flapping in the wind there. Okay, so in terms of abdominal ultrasound, this is where it becomes um, really not like we're not really useful, or sorry, it's not clear as useful. I won't say that, but in the ER, it's quite useful in terms of FAST, which is the abdominal ultrasound for trauma. But really, does it translate into something useful in the ICU? Does it change anything? Really, just binary questions again. Is there fluid? Yes or no? And it doesn't really like. I think it's useful to know sometimes. Like there's been some examples recently where you're like, okay, yes, they've got lots of fluid, but really doesn't change a whole lot of the management. So I think it's useful in the sense that this is in terms of most ICU ultrasound courses. Um, this is really a very easy way to learn ultrasound is by starting with abdominal. You can get the views very easily. And once you get the views in the abdomen, you can move up the rib spaces into the chest really easily. So I think it's useful in some ways, but I don't think there's a giant aha moment for using abdominal ultrasound in the PICU. So you're basically looking for fluid in the belly. Is there blood fluid around the heart, blood fluid in the chest, or pneumo? That's so the all of these are the similar. You can get this from the FAST in the ER, and that's similar to what we're looking at in the ICU. So these are your abdominal views. Um, so on the this is your normal abnormal. So you can see this is the head is always the head of the this is like a cross-sectional view. The head is always to the left, where the I can't seem to get my thing to work, but so you see the green dot, that's towards the patient's head, the liver and the kidney. So that's sort of Morrison's pouch, and abnormal, as you see on the right, there's a sliver of black. Black, that's where so you know there's free fluid. And then the one on the bottom right, there's a large amount of free fluid. So that's kind of the right upper quadrant view, and that's where most kids are going to have pool fluid, depending on how they've been transported. If they've been transported left side down, obviously they'll be pooling onto the left, but most of the time, the right upper quadrant view will be positive if there's fluid. So then we get to cardiac ultrasound, which is really where people really want to get answers for. But this is where we run into trouble, and as intensivists, PICU and NICU, where we really have to be careful about overstepping. And really, I'm very keen on just asking specific physiologic questions. And again, I will reiterate, I don't know if there's any cardiologists on, but they will, there's lots of stories of people trying to replace the formal echo or formal cardiology consults with this, and it just doesn't work. And so the way I look at it is it doesn't replace anything. Like the example that I showed at the very beginning, you look for something. So in that scenario, you're looking for LV function, parasternal lung. You see, oh my God, like what the is this? And it's obviously a cardiology consult at that point. So very specific um, physiologic questions. And that's where I find it. This is where I think it is super useful, but only in the sense of using it as another vital sign per se. It's very helpful to do serial exams. Like I find this very helpful in the post-cardiac arrest population, where we see a really dramatic cardiac stunning post-arrest, and you can very clearly see the ventricle getting more vigorous over the 24 hours. So that's where this becomes very useful, and we don't have to bug cardiology all the time. And again, we're not quantifying per se and we'll talk about that in a second. So the rationale, this is for the physiology people in the crowd. So your DO2 is your oxygen delivery is equal to your cardiac output times your oxygen content. And the cardiac output is derived from preload, afterload, and contractility. So that's kind of the preload and the contractility is where people are trying to get answers from, and they're trying to make ultrasound be that thing. And it can to a certain extent, but there certainly are limitations. I've used this slide in almost every talk I ever give. This is from the late 90s. So this is back in the era of Swan catheters and other invasive cardiac output monitors, where you've got the measured cardiac index on the bottom and the estimated on the y-axis. And the point of this was they took a bunch of intensivist med students, fellows in England, and they had a cardiac output monitor in, and they wanted the people to examine the patient and guess what the cardiac output was based on their very seasoned clinical exam. And for the statisticians in the crowd, this is essentially just basically a coin flip. And really, people had no idea. And it didn't matter how experienced you were. There's really which I find very sobering, that we don't really have a sense. Cap refill, all of that is really, we cannot guess the cardiac index based on our clinical exam. So that's where ultrasound has been heralded as a tool. So I think looking again, systolic function, fluid status, pericardial fluid, those are really the only things that you should be looking for. You're not looking for ASDs, you're not looking for VSDs. You can't, and valve regurg, etc. I think that's advanced. I don't think that's for all of us. I think that's a cardiology thing. We can look at sizes of the ventricle, and again, you're looking for things like there's a very clear example the other day. Uh, the child in room 8, back a couple of weeks ago, we did this. The RV looked what I thought was a bit large and abnormal. We got cardiology opinion. They agreed she had sort of two-thirds systemic RV systemic pressure. She was started on nitric and improved dramatically. So that again is sort of the algorithm of where echo becomes super useful. Okay, so this is a while back, 20-month-old. Right, he had an arrest in the OR post laparotomy. He comes to the ICU. He's had multiple arrests, had ROSC, not ROC, fluoride shock, massive doses of norepi, volume infusing, lactate was climbing. So at this point, you're like, well, what should we do? Like we're really like fluid inotrope pressor resistant. What do we do? Get more fluid, more pressor. And so you're looking at the pumps, you're looking at the systolic function. This is a subcostal view, and you're looking just does the LV look normal or not? The LV is on the right side here, so it's sort of at the bottom right. And I can't see if there's cardiologists on, but this looks like a moderately depressed, mild to moderate depressed LV function. So this you're like, okay, well, this actually maybe the norepi at this point is actually causing us more harm than good. The tank. So this is your IVC. And again, we'll talk about the IVC in a second. So you're looking at the IVC view just under the Xife, and you're trying to determine mostly by eyeballing, does the IVC look really compressed, or is it distended and not moving? And this child looks like it's not really moving. It's pretty distended. There's a lot of caveats to the IVC. I'm not a giant believer in numbers in the IVC. I think it all depends on the clinical context. So this in the sense of so what do we do now? We've got tons of norepi, lactate's getting worse. Do we need more fluid, or do we need to switch our strategy? So what did we change? So we based on that IVC, we said no more volume. We looked at the left ventricle. We thought, this doesn't look great. So let's add some more inotropy and less afterload squeeze, and lactate improved, patient stabilized. So very good example of what we use a point of care echo for. Again, you're not saying you're not diagnosing anything other than LV dysfunction. And again, cardiology can be helpful as a second look, or I guess just a second opinion. But at the bedside, when you're trying to sort of manage things in the evening or something like that, it is helpful. And there's been lots of studies to show that we as intensivists can quote unquote eyeball function fairly well with very little training. And again, you're not calculating ejection fractions. I think that's when we run into trouble, when we try to be radiologists or cardiologists. So this is just sort of eyeballing, right? So this is a parasternal short, top right here. This is your LV, RV's on top. This is what normal looks. So you can see the squeeze on the left versus the squeeze on the right. Like, I'm not Rini. I don't know if Rini's on, but like I can tell that that's abnormal, and that's helpful to know. You don't have to know why, but okay, well, there's something going on that doesn't look right. I'm going to change my strategy. And then this is where it becomes even more useful, and this is very helpful in patients that have a cardiomyopathy or myocarditis or something that you because it really does change. It changes your RSI management, it changes your fluid management, it changes everything. So I think this is very useful, and this is very obvious to most people that are watching that that's severely abnormal compared to normal. Left. So again, left normal, right not so normal, and look at, so even on the right you can see how the the LV is almost just shimmering and just shaking as opposed to squeezing. Like it's just so very abnormal. This is just looking at PEM docs. This is a long time ago. This is 13 years ago. PEM docs versus cardiology, and cardiologist versus a PEM physician. And what you're just seeing here is very good compatibility. The kappa values are quite good between determining LV function. You just deciding if the LV is not working well, pericardial effusion or abnormal IVC. So again, it's not that hard to get these skills. In terms of volume assessment, this has really become the holy grail. And everybody has really tried to make sense of this and how to really decide who needs fluid and who's not. We've kind of all thrown out CVP now. Every ICU pretty much doesn't use it anymore. But the whole point of a fluid bolus is, do you increase your cardiac output or stroke volume with a fluid bolus? And as you guys know, there's lots of evidence now that excess fluid leads to morbidity and mortality. So we really are trying to limit fluid and, or sorry, like a fluid overload, and trying to decide who needs fluid and who's not. So this is just a Frank Starling curve on the left, which I use all the time teaching because I think it's very useful. And you can just see, I wish I had my thing back, but the upper curve is a normal heart, the bottom curve is a failing heart. And the whole point of this is a given amount of preload or fluid bolus has much different changes in stroke volume depending on where you are on the curve. And I think this is the whole point of cardiac ultrasound in the ICU, is to determine where you are on that curve. This is also super interesting. This is the Merrick-Phillips curve, which is just the upper curve, the black curve in black. And so that basically looks at extravascular lung water or pulmonary edema. And so if you've got, when you're at the flat part of the curve on the bottom, the Frank Starling curve, and you give a bunch of fluid, you're getting a large increase in extravascular lung water. So the whole point of, for me, and when you're dealing with patients that are hypotensive or in shock, is deciding where you are in the curve. So does it help? Oops, sorry. So we've tried a lot of different things: IVC to aorta ratio, IVC collapsibility. There's a VTI. There's subjective eyeballing in the short axis. All of these are kind of lacking. Sorry. So what I tend to teach is basically you're looking at the IVC in the clinical context. So like the example of the patient I just had, if that patient had a very flat IVC, you're like, oh, okay, they probably could do with some fluid. That in the case that I showed you, that IVC was quite distended. Again, there's lots of caveats, the PEEP, whether or not the kid's spontaneously breathing, et cetera, et cetera. So I think if you look at the IVC in the extremes, you get a better idea, as opposed to trying to look for numbers in terms of 50% collapsibility, et cetera, et cetera. Don't think it's useful. I think you have to just look at it as another vital sign, per se, when you're trying to make the assessment of what this kid needs to fix their physiology. So this is the big question, though. Does it change management, improve outcomes? So the outcome data is coming. Again, kids don't die very often of shock, so it makes these kind of studies very difficult to do because they're very hard to get mortality data. So I think there's lots of potential here. There is some burgeoning data that I'm not sharing here that shows echoes that change management, just like I see. So the data in using daily echoes, or sorry, not daily echoes, but serial echoes with kids with hypotension and shock is really useful in terms of changing your strategy. There's a couple of very keen ICUs in India that use point of care echo very effectively to try to come up with strategies. Again, I try to stay away from very prescriptive algorithms for what you should do based on what the echo is. I think it's all very much, we should all use our own experience and what the patient's telling us, like what the heart rate is, what the blood pressure is, what does the echo look like, what makes sense, as opposed to like being very prescriptive in a sort of report style of like an echo report. Um, so I think it's getting there, and I think it's important to use. And I think we didn't um, like I think we just have to be quite careful about how we don't overstep things, and I've said that a few times. So in terms of this, so looking at some of this evidence, this is adult patients in the emerge department with septic. So 50% had management change with echo compared to what the physicians would have done. This is one of the Indian studies. Um, they categorized shock based on fluid refractory or not, cold versus warm. And it's a very busy slide. I don't want you to look at the specifics. So it's basically 88% had management change. They had a huge survival for like that's probably what our survival is in septic shock, at least 92%. In India, that was a giant change in terms of their overall survival profile. So using focused echo in their population was very helpful in terms of tailoring their management. And that is really the big trend in ICU management, using data that the big giant data sets that Val's going to be involved in, and looking how to personalize our therapy. This is what I just said, tailoring approach, different physiology requires different therapies. Thoughtful fluid replacement should be the, and so I have changed. That's in terms of what my practice is. I think I use a lot less fluid, a lot more pressors than I thought. So we all hear this is probably 20 years ago, an old PALS algorithm where you see ultrasound at the very end in terms of persistent catecholamine resistant shock. This is back like when I started training 20 years ago. This was, or started practicing. This was kind of, you see at the top, uh, 60 cc's per kilo in the first 15 minutes, which is feasible, but that's kind of where things were. And I think this is kind of more where things are now. So your usual care monitors, IV oxygen, check the glucose, you give a fluid bolus, and then you do your point of care echo. You can and then determine IVC flat, LV function decrease, LV normal. So this is a very easy algorithm. It makes a lot of sense, and you can get onto epi, norepi very quickly, and that can prevent fluid overload. And this is where some of the other ICU modalities, so there's neurosonology, so neural ultrasound, so that transcranial ultrasound and optic sheath diameter to interpret ICP changes. I'm not skilled at that. It's tricky to do. I've tried the transcranial. It's very, so you're basically looking at the vessels through the temporal bones, and it's tricky, and it's, again, if you don't, this is looking to predict ICP changes, which I guess the question is, how useful it is in the setting of someone who's got an ICP monitor. Airway ultrasound to assist in intubations. This was kind of becoming in vogue before we all switched to video. So once we've switched to video, it's not quite as useful. There is some evidence that diaphragmatic ultrasound for vent weaning is helpful. I have not used that, but there is some evidence and research to support that. And then point of care echo during cardiac arrest, and that's kind of interesting in terms of I've used that a fair bit because I think it's not so helpful to determine when to stop, but it's helpful for the people in the room. Like I've used this a fair bit in the ER. When you're doing a resuscitation, because it's helpful for the people, like the people being like the other like nurses, RTs, etc., to say like, look, like the heart is like, if you're 30 minutes in and it, obviously it's very hard to stop resuscitating a child, but it is helpful to have that evidence, like the heart is just dead, there's nothing going on. So that's kind of a useful rule out, and there's lots of others. So we talked about all of this already. This is just sort of reiterating where we are in terms of resuscitation. So this is, I was part of this. This is like the initial group of us. There's probably 4 or 5 of us on the author list that um, we were kind of the ones that have started teaching at the institutional level, at the society critical care medicine level in the US. That's 10 years ago now. So this is probably 3 years old, where we're looking at how to translate these skills, because there really hasn't been great buy-in. I think the pandemic, it was a huge problem in terms of getting us uh, on the same page to standardize things. So this is uh, we'll see Yasser's name. I think he's on this somewhere, maybe not. Yasser is important in the NICU world. This is a European guidelines in terms of what this is probably last year's data. So there's at least 70%. And have the key is the program specific education. And that's where the piece is that's hard to sort of know what to do next. Only, and at least I think 25% is probably a stretch, have any credentialing. The only place that I know that really does this well is Children's Hospital of Philadelphia, and they have they have a huge amount of patients and a huge amount of resources. But we do need to do better in terms of admit, program development, credentialing, et cetera. This is where um, uh, the question about not stepping on toes and getting buy-in from our partners in cardiology and radiology. So we really need to identify these applications that are encountered frequently, amenable to ultrasound, and that have really discrete outcomes. And the adult ICU, like I said, have had these really well-defined position statements, and we're just getting there as a group. So how to educate, teach this? There's lots of different options. Focused training leads to decent acquisition of skills. Like the transport team has been going through that recently, and they have developed pretty decent skills, certainly great vascular access skills, and then they're just getting into using it for hemodynamic management in the field. So, like again, lots of teaching at these workshops, but then you bring them home and you don't really have a champion. So that's the biggest issue in terms of getting competency certification. And you kind of have to take into account the local environment, resources, et cetera. And so like this is just an example. Like I think I don't. This is an old document from the American Society of Cardiography, and they're looking at least 150 transthoracic echoes and at least 50 in age less than 1. This is what their recommended methods of training uh, are for a pediatric echo. So these are things that we have to sort of take into account as we try to decide what somebody needs to become proficient. And then I again, this is the TNE, so this is the NICU, and again, NICU has really upped the game in terms of what their level of involvement in ultrasound is and what their level of training is. There's lots of controversy. They might have pigeonholed themselves a little bit in this. So I don't, in terms of like having to have all this training and what does it actually mean and what does it actually get you. But they have been a leader in terms of trying to get some recommendations for training. And this is the group from Philadelphia that has been the leaders in this. And I basically they've developed the most comprehensive program. And even with them, if you look at their publications on this, it's really very few numbers that are actually credentialed per se. In the US, it's a much different uh, ball game because of um, billing and credentialing and insurance and liability. So it's a bit different in Canada. But for us, the quality assurance image storage is a big issue in terms of just storing the images and looking at them and so that other people can help us decide if we were right or not. Um, and so that's kind of where we are lacking in Canada. And I think I think we really need to decide as a group of intensivists what we need to learn and come up with some very simple guidelines and really don't overstep. Um, the big thing that I think we are really lacking, like I just said, is quality assurance and documentation. And I have not been great at that at times. And I think we've tried here in Winnipeg to try to develop some archiving solutions. It's been very difficult with um, health information systems and like talking to each other, the expense of putting things on packs, which was an option. It's all have been a giant challenge. So we're kind of back to just sometimes storing them locally on the machine itself. Our old machine, we used to store and I would try to interpret. I've not done that with this one. So it is a work in progress. And I think we need to do better with that. I think as the technology becomes smaller and more ubiquitous, like med schools, et cetera, I think we're really going to be forced into making this a bit more standardized. I think that's everything. Bell?
Yeah, thank you so much. That was awesome. Nobody wrote anything in the chat.
Oh, that's interesting.
Um,
That
I know
was just,
they just everything you said, no questions. No, I'll open it up. If anybody has, you can turn on your camera, you can raise your hand. I guess um you're just getting comments so far that it was great, so that's good. I like my question was kind of a lot of what you said at the end because when I was in training, it was still very controversial, and it wasn't that long ago when I was at Sick Kids about how much you would use it for even point of care. Like vascular access, agree, it was no question you had to do it. But for anything else, it was really questioned by people and not really something that was encouraged at that time. And so, like, for me, I would say I'm can do it for the things that you just kind of talked about, those key things and following along, but I wouldn't say I'm like credentialed in it because I never had that, review of what I'm seeing. So like how would you view us moving that forward in our own program or like people who've already been working for a while, how do we get to that point or do we need to?
well, you can, yeah. I think the first thing is, I think we need to come up with a archiving solution so we can save all our images and then we can sort of look at them and see where we're all at. There's no real Canadian places that are credentialing anybody because it's really a crapshoot about so we're making stuff up. Like with the transport team, we were like, so they had, I don't even remember the X number. I think it was 10 to 15 focused echoes that had like four decent views that I proctored and looked at and said, so okay, you're reasonable. This is reasonable. So yeah, I think archiving is first, and then quality assurance coming up with like a template about what the acceptable things are that you need to see in an echo or lung or thoracic ultrasound, and then kind of go from there. But there's really no credentialing out there, and we don't. And Canadian hospitals, you would know better than anybody, are not great at this.
Agreed. Okay, that's fair. I agree with that. Oh, BJ, you have your hand up. Go ahead.
I am in the car, so I'm not going to turn my video on. But Jeff, that was an excellent presentation. I really enjoyed it. I think we should each encourage ourselves to keep progressing. I know I've advanced a little bit over the years with learning this skill set, but I'm not anywhere close to where you are. I think the really valuable thing is that it is an important tool, and that's what it is as a tool. And you keep telling us that it's not for diagnostics and stuff like that, but it does help with identifying issues that need further investigation. And I think we are all responsible to know our limitations. And if you find something that's not normal, at least to me, it can justify asking others to come in, even if, especially in the middle of the night. Like if you can identify that the heart is there's something wrong there, And then we can say that, you know, they really do need to come in the night to help us out with an
Yeah.
unstable patient. I think that's important because it's just using a tool and identifying issues that can guide us along the way. So yeah, I think we should try to keep moving on that and help each other learn the skills. And we're very fortunate to have you because you've kind of spearheaded this and been a leader in this in PICU. So thank you.
Yeah, no, I agree. I think you talk to, like, there's been a few issues. I don't think there's any neonatologists on, but in terms of the NICU is real, like there has been some challenges with them for sure in terms of the interaction with cardiology and Rini, and I have talked about this a little bit. Like there's, but and I've not gotten into trouble, but like the main thing, like I keep is we have to figure out how to save these things. So like I can look at this look at this with Rini and say, look, like this is what I saw. What do you think? And then replay that. And I've run into problems in the past, distant past now, where I've seen stuff acted on them, and then they've come a day or two later, and they're like, well, when did this start? And I can't show them the image. Like it is important that we work with them because there has been some friction with the NICU for sure and how they're generating images.
Yeah. Well, I can't speak for NICU, but I have found a few times where they actually did not consult other specialties.
No, exactly.
Acting on their own ultrasounds or whatever. And that's not okay to me.
No.
But it would be nice to save that. And I think I agree. We need to push forward on that because I don't know, when you just look at an example like an EKG, I mean, we can send that to cardiology in the middle of the night. They can read it and call us back with their thoughts on that. And
Yeah.
if we could just do the same with an ultrasound and show it to them,
Yeah.
it may not be up to the caliber that they would do, but if it just says that,
Yeah.
they need to come in, they need to call the echo tech in and all of that and come and do a proper study. And it gives them enough information to know that there's something that needs further investigation. I think that's valuable. That's really valuable. So yeah.
Yeah, like the example from that I keep talking about Rini because it's usually Rini and I talking about this, but they're the child that had that we ended up that we've sort of started our ECMO program because of the CI was a very good example of what I thought at the time was a perfect interaction with what, like, I should have used that case because it's very, very good. Like in terms of me, I was in the ER at the time and we treated the child for sepsis for about half an hour until we put the probe on and realized the heart wasn't really moving. And so I called Daryl. Daryl came in, and we were packaging, and Sasa was on, and we were packaging the kid up to go to Edmonton when he unfortunately arrested and died basically in the hallway of a malignant arrhythmia. But that for sure would have taken 6 to 12 hours. Like this was at midnight, right? So cardiology, like BJ said, cardiology came in. We made the diagnosis: myocarditis, complete heart block, ventricular failure. And unfortunately, the kid passed away because of a variety of things, but not because the diagnosis was delayed.
Yeah, I would agree with that too. Like I've even taken videos on my phone, like in the confidential way that you can send it to the cardiologist on like Tiger Text or
Yeah.
and it's been very helpful. So I would agree. I do see that there is some neonatology on here, so I don't know if they have any comments or if anybody else has any questions in the audience or nope, doesn't look like it.
Okay.
Okay. Any final statements you want to make, Jeff?
Yeah. No.
Okay.
Good.
Hey,
Thanks.
well, thanks everyone. Thank you for that great presentation. I will get everybody the schedule for the new year soon and hope everybody has really good holidays. So happy holidays, everybody.
Thank you.
Thanks.
Happy holidays. Thanks, Jeff. Thank you.
Okay.
Thank you.